Welcome, curious minds, to a deep dive into a microscopic threat with truly monumental implications. We're talking about equine herpes virus.
EHV.
Right.
Yeah.
EHV, a silent force, really, that profoundly impacts some of the most magnificent animals on Earth. What we uncover today might reshape how you think about equine health.
It really might.
Our mission, basically, is to cut through the complexity of EHV, focusing on its two most significant types. EHV-1 and EHV-4 will explore their crucial differences, how they, show up.
How they manifest, yeah.
Exactly. And most importantly, what it all means for preventing and caring for our equine companions.
And this understanding is absolutely, well, crucial. Because while EHV often causes what seem like common respiratory sniffles, maybe a cough,
Right.
EHV-1 in particular can lead to devastating reproductive failures and crippling neurological diseases.
That sounds incredibly serious.
It is. This makes it a primary concern across global horse populations. So, grasping the nuances of this virus isn't just academic. It's essential for safeguarding our equine friends and the entire industry that supports them.
To truly grasp this challenge, let's start with the fundamental question. What exactly is equine herpes virus?
Okay, so at its core, EHV is a virus found, well, pretty much wherever large groups of horses gather.
So everywhere, basically.
Pretty much, making it a truly global challenge for horse health.
Okay.
But what's often overlooked and truly fascinating here is the concept of latent infection.
Latent infection, meaning it hides.
Exactly. Imagine a ticking time bomb in your horse, completely hidden. That's the chilling reality. Horses can carry this virus for years without a single outward sign.
Wow. No symptoms at all.
None. It just lies dormant in a quiet phase. But then during periods of stress, it can recruit that is, reactivate.
Reactivate. Okay, what kind of stress triggers that?
We're talking about stressors like shipping to a new barn, weaning foals, intense training or competition, overcrowding.
So the usual suspects for horse stress.
Right. Even surgery or other illnesses can do it. This ability for the virus to go dormant and then just erupt makes controlling its spread incredibly challenging.
So once it reactivates, how does this virus actually get around? How does it spread?
Well, we're talking about the common transmission routes, aerosol, like those invisible respiratory droplets from coughing or nasal discharge.
Okay, breathing it in.
Yeah. Then there's direct nose-to-nose contact. And don't forget indirect contact via fomites.
Fomites, right, contaminated stuff.
Exactly. That's contaminated equipment like feed or water buckets, tack, grooming supplies, stalls, trailers, even human hands or clothing.
Gosh, the list is long. It sounds like it can move really easily.
It really can. And here's a critical detail that often catches people off guard. It's not just sick horses shedding the virus that spread EHV-1.
Oh.
The aborted fetuses and even the placental tissues from an infected mare. They are incredibly potent reservoirs for the virus.
Oh.
Highly contaminated.
Oh, wow. It's quite grim.
It is. Imagine the devastating ripple effect. A single abortion can unleash a massive viral load, turning a tragic loss into a viral hotspot that fuels an entire outbreak. That's the silent, insidious power of EHV-1.
Now, here's where the plot thickens. You mentioned EHV-1 and EHV-4. It reveals the true cunning of this virus, I guess. Well, they might sound similar. They're like two very different siblings, right? Each with a vastly different impact. Let's peel back the layers on those crucial distinctions.
Exactly. So EHV-4 is primarily what we call a respiratory troublemaker.
Okay.
It's very common in young horses like weanlings and yearlings, and it usually stays limited to the upper respiratory tract.
So milder symptoms?
Yes. It means it causes a generally milder disease, it rarely causes abortion, and it's extremely rare as a cause of neurological disease. So while it's a nuisance, causes coughs and runny noses.
It's typically not the major disaster.
Right. Not usually the catastrophic one.
Contrast that with EHV-1, which you said is often considered the more concerning big player.
That's right. Its pathophysiology is unique, how it works in the body. EHV-1 is a stealth invader. It hitches a ride inside white blood cells.
Inside the immune cells?
Yeah, literally using the horse's own immune system as a Trojan horse to travel freely throughout the body. This causes a viremia.
Viremia, meaning virus in the blood.
Correct. The virus isn't just localized, it's literally circulating throughout the horse's bloodstream. This systemic spread is why EHV-1 has a much wider range of severe outcomes.
Because it can get anywhere.
Exactly. Notoriously reaching the reproductive tract and the central nervous system, unlike EHV-4, which typically remains localized usually just in the respiratory system.
Okay, that makes sense.
What's also important to note is that some specific neurotropic strains of EHV-1 share a common genetic mutation.
A genetic difference in the virus itself.
Yes, and this mutation seems to result in more prolonged viremia, a longer period of virus in the blood, which is thought to be a key factor potentially contributing to the development of neurological disease. So it's not just that it can go systemic, but some strains are genetically predisposed to be better at it, maybe stick around longer in the blood, leading to those more severe neurological outcomes.
So what does this big player, EHV-1, actually do then? You're saying it manifests in different ways.
It does. It's a bit of a shapeshifter. It can show up in three distinct, often devastating syndromes. A horse might get one, or a combination.
Or nothing at all.
Or even lurk silently as an asymptomatic carrier. Exactly.
Okay, so what are the three main syndromes?
First, we have respiratory disease, also known as rhinopneumonitis.
Rhino. Okay.
This is the most common form for both EHV-1 and EHV-4, especially in young horses. Signs include a cough, a thick, often yellowish nasal discharge, mucopurulent discharge depression, maybe abnormal lung sounds.
Sounds like a bad cold.
It could look like that. Specific to EHV-1, there's often a fever, which can be biphasic.
Biphasic, meaning two phases.
Yeah, an initial peak, then it drops, then a second peak maybe 4 to 8 days later. Sometimes that fever, typically between 102 and 106 Fahrenheit.
That's quite high for a horse.
It is. And sometimes that fever might be the only sign you see. Recovery is usually mild and self-limiting, maybe 1 to 2 weeks. Usually. However, there's a rare, more severe form that affects the blood vessels in the lungs, the pulmonary vasculotropic form, which can tragically be fatal.
Okay, so that's respiratory. What's the second one?
The second really serious outcome is reproductive tract disease, specifically abortion.
Ah, the one breeders dread.
Absolutely. It's a major cause of viral abortion in mares. This typically happens in late-term pregnancies, around 7 to 11 months, but it can occur as early as 4 months.
And does the mare get sick first?
That's the heartbreaking part.
No.
Often mares show no clinical signs of illness before aborting. The abortion can happen weeks, even months after the initial exposure.
Oh, that's awful. Delayed reaction.
Very much so. EHV-1 can also trigger what are known as abortion storms.
Abortion storms. That sounds devastating.
It is, where you see widespread rapid abortion sweeping through a susceptible mare herd. It creates immense emotional and financial strain.
I can only imagine. And the fetus itself.
The aborted fetuses themselves may have issues like pulmonary edema, fluid effusions, spots of dead tissue in the liver, multifocal hepatic necrosis jaundice, or small pinpoint hemorrhages. And crucially, these fetuses, along with the placenta and fetal fluids, contain enormous viral loads,
making them highly infectious.
Extremely significant sources of further infection.
Okay, so respiratory, reproductive. What's the third phase of EHV-1?
And finally, the most severe and feared manifestation, neurologic disease, or equine herpesvirus myeloencephalopathy.
EHM.
EHM, the neurological form. This is the one that makes headlines, isn't it?
It often is, yes. This form is caused by vasculitis, a dangerous inflammation of the blood vessels, specifically in the brain and spinal cord.
Inflammation of the blood vessels. How does that cause neurological signs? That inflammation leads to the formation of blood clots, thrombi, within those small vessels. These clots block blood flow, causing ischemic neural damage, basically. Parts of the nervous tissue die from lack of oxygen, and that causes the characteristic clinical signs.
What kind of signs are we talking about?
Well, these signs often follow a fever or maybe mild respiratory issues, but sometimes they can just appear abruptly, out of nowhere. Yes. You'll often see an acute onset of hind limb ataxia, a noticeable incoordination, wobbliness, often coupled with what vets call proprioceptive deficits, meaning the horse struggles to sense where its limbs are in space.
Difficulty knowing where their feet are.
Exactly. And it can progress from the hind limbs to affect all 4 limbs. In its severe form, it leads to hind limb paralysis, often resulting in a dog-sitting posture or recumbency, where the horse simply cannot stand up.
Unable to stand, that's critical.
It is. You also commonly see the bladder becomes paralyzed, leading to urine retention and dribbling, fecal retention, loss of sensation around the tail and perineum, and decreased tail tone.
So trouble peeing and pooping too.
Very common. Rarely you might see cranial nerve abnormalities like a head tilt, tongue weakness, abnormal eye movements, nystagmus or blindness, and even seizures can occur.
It sounds absolutely devastating.
It can be. And EHM can appear as isolated cases or, unfortunately, as devastating outbreaks affecting multiple horses. While the median age for hospitalized horses with EHM is around 3 years, really any age or breed is susceptible.
Wow. Okay, so with such a cunning and varied opponent, such different ways it can show up, a crucial question arises. How do veterinarians definitively diagnose EHV when symptoms can be so diverse, maybe even subtle sometimes?
That's a great question. Accurate diagnosis is absolutely crucial, both for biosecurity stopping the spread and for effective treatment or at least management.
So where do you start?
It starts with clinical suspicion based on the signs you're seeing: fever, respiratory signs, abortion, neurological signs, and the epidemiology. Is there an outbreak nearby? Has the horse traveled? Then comes sample collection.
What kind of samples?
Samples are best taken when the horse is febrile, when it has that fever, or right at the onset of signs. This includes nasal or nasopharyngeal swabs to look for respiratory shedding of the virus.
Okay, swabs from the nose.
Right, and critically, whole bloods, specifically the buffy coat, which is the layer of white blood cells where EHV-1 likes to hide, collected in a special tube, an EDTA tube. This is essential for EHV-1 because it causes that cell-associated viremia we talked about.
The virus in the blood cells.
Exactly. Finding it there indicates a risk for the more severe outcomes, like abortion or EHM. For reproductive cases, obviously, aborted fetuses and placenta tissues are ideal samples. Tissues like lung, liver, adrenal gland, lymphoid tissue are best.
And what happens with those samples? What tests are run?
For laboratory tests, PCR, or polymerase chain reaction, is really the diagnostic test of choice now.
PCR, like for COVID.
Very similar principle, yeah. It's highly sensitive, very specific, it detects the viral DNA directly, and importantly, it can differentiate between EHV-1 and EHV-4, and even identify those neurotropic strains we mentioned.
And it's fast.
Relatively fast, yes. You can often get results within 24 to 48 hours, which is critical during an outbreak.
Are there other tests?
There are. Virus isolation used to be more common, but PCR is generally preferred now. And then there's serology, which measures antibody levels in the blood.
Antibody titers.
Right. A four-fold increase in the titer between an early sample, the acute sample, and one taken 2 to 3 weeks later, the convalescent sample, indicates a recent infection.
Right.
A single positive titer on its own isn't definitive. It could just mean the horse was exposed in the past, or it could be from vaccination. So it needs interpretation.
Got it. Any other procedures?
Sometimes vets might do a CSF aspirate, a spinal tap, especially for neuro cases. The cerebrospinal fluid might show increased protein, maybe a yellowish tinge called xanthochromia, which can suggest inflammation or old bleeding. Imaging like chest x-rays might be used if secondary pneumonia is suspected.
That's a lot of ways to get to a diagnosis, showing the complexity. It's also worth noting you mentioned fever. Fever is a key aspect of this herpes virus, myeloencephalopathy, the EHM. Right. And that's uncommon in most other equine neurologic diseases.
That's a very important point, yes. Fever is a hallmark of early EHM, which helps differentiate it from many other neurological conditions in horses, with the notable exception of West Nile virus, which can also cause fever and neurological signs.
Okay, so diagnosis is key. What about treatment? If a horse is diagnosed, what can be done?
This is the tough part. It's really important to emphasize that there is no specific cure for EHV infection. There's no magic bullet antiviral that just wipes it out.
No cure. So what do you do?
Treatment is largely supportive. It's focused on managing the symptoms, preventing complications, and basically buying the horse's own immune system time to fight off the virus.
So what does that crucial supportive care involve? What does it look like?
Well, first off, rest. Rest is absolutely essential for all forms of the disease. For uncomplicated run-up pneumonitis, the respiratory form, that usually means 2 to 4 weeks of rest.
Just rest, no work.
Exactly. For more severe respiratory infections, horses really need a full month to allow the airway lining, the epithelium, to heal properly. If training is resumed too early,
Problems.
yeah, it can lead to persistent airway inflammation.
Yeah.
Then anti-inflammatories, like NSAIDs, nonsteroidal anti-inflammatory drugs such as flunixin megalamine or phenylbutazone, bute. They're used for fever and inflammation.
Okay, managing fever and pain.
Right. Corticosteroids like dexamethasone might be used for severely affected neurologic cases to try and reduce that CNS inflammation, the vasculitis. But their use is controversial.
Why controversial?
Because of the significant risk of causing laminitis, a very serious hoof condition, especially in sick, stressed horses. So it's a risk-benefit calculation.
Understood. What else?
5E fluids are critical for hydration, especially in horses that are febrile, not eating well, anorexic, or those EHM cases with bladder dysfunction.
Right, the bladder paralysis.
Exactly. And for EHM, bladder management is absolutely critical to prevent the bladder from rupturing or getting infected. This means manually expressing the bladder or using urinary catheterization, often at least twice a day.
That sounds intensive.
It is. And those recumbent EHM cases, the ones that can't stand, need incredibly intensive nursing care. Think thick bedding, frequent turning to prevent pressure sores, maybe using slings or hoist assistance to get them up periodically, trying to prevent secondary problems like pneumonia and muscle damage.
Wow.
And finally, antibiotics might be used, but only if there's evidence of a secondary bacterial infection like bronchial pneumonia, complicating the respiratory form, or a bladder infection, cystitis, from the catheterization.
So antibiotics don't fight the virus itself.
Correct. Only secondary bacteria. It's an intensive effort, really, just providing these animals the best possible chance to recover.
You mentioned no cure, but what about antiviral medications? Are there any that help at all?
That's a good question. There are a few options, but their efficacy, especially once significant neurological signs are established, can be debated. Valacyclovir, which you might know as Thaltrexity in human medicine,
Right.
it's an oral medication that converts to a cyclovir in the body. Its effectiveness in treating established EHM is still not definitively proven. Some studies suggest it might help, others less so.
So maybe helpful, maybe not?
It's debated. However, it may be considered for horses that are febrile, have a fever before severe neurological signs develop.
As a preventative measure, almost.
Kind of. The idea is it might potentially reduce viral shedding and the level of viremia, the virus in the blood, and possibly decrease the risk or severity of EHM developing later. But it's important to note it's expensive and requires frequent dosing, often multiple times a day.
Okay. What about a cyclovir itself?
Oral acyclovir, the drug valacyclovir converts into, is generally poorly absorbed in horses, so it's considered less effective when given directly by mouth.
I see. Any others?
There's ganciclovir, which is given intravenously. It's a more potent antiviral against herpes viruses, but
A bite?
it's very expensive and not widely available for veterinary use. So, realistically, valacyclovir is the main one considered, despite the ongoing questions about its definitive benefit in established EHM cases.
So with EHV being such a pervasive and tricky virus, and treatment being supportive rather than curative, prevention seems absolutely paramount. How significant is vaccination in our overall defense strategy, especially given what you just said about antivirals and the neurological form?
You've hit on the key point.
Yeah.
Controlling EHV requires a truly comprehensive approach. It's not just one thing. It's combining vaccination, really strict biosecurity, and active surveillance.
All right, let's break that down. Biosecurity first.
First and foremost, yes, biosecurity and isolation. This means immediate isolation of any suspected EHV horse, especially if they have a fever or any neurological signs. Full stop. Separate them immediately.
Makes sense.
Then you need rigorous hygiene protocols. Thorough disinfection of stalls, equipment, dedicated handlers, clothing, footwear for isolated horses, constant hand washing. Treat that isolation area like a biohazard zone,
Total lockdown for that horse.
pretty much. And movement restrictions are paramount. No horses should enter or leave the premises during an outbreak until it's declared safe.
How long is that usually?
Typically 21 to 28 days after the last clinical case resolves or after you get confirmed negative PCR test showing the virus is gone.
Okay, a good few weeks.
At least. And daily temperature checks, ideally twice daily, for all horses on the premises are essential to identify new cases early. Catch that fever spike.
Vigilance for everyone.
Absolutely. Affected facilities require prolonged quarantine. And it's important for people to know that neurologic EHV-1 and sometimes EHV-4 if it causes neurosigns, is a reportable disease in many states in the USA. You have to notify authorities.
Right, public health aspect.
Exactly. Also, remember, horses recovering from infections can shed the virus from their nose for maybe 2 weeks or even longer, so they need to remain quarantined even after they seem better.
Still shedding.
Yes. And finally, going back to the reproductive form, proper disposal of aborted fetuses and fetal membrane-sealed container handled carefully is absolutely critical because of those extremely high viral loads we talked about. You have to treat the whole premises like a fortress under siege during an outbreak.
Okay, that's the biosecurity fortress. Now, what about vaccination? You mentioned it's part of the strategy, but earlier you said no vaccine currently prevents the neurological form, EHM. So what's the ultimate goal of vaccination here?
That's a crucial distinction and a really important question for owners and veterinarians. Vaccination is another critical component of the overall strategy. And yes, Its primary proven benefit is to help reduce the severity and frequency of respiratory disease.
So fewer coughs and runny noses.
Yes, and maybe less severe cases. And importantly, it helps decrease the amount and duration of viral shedding.
Uh-huh. Less virus being spread around.
Exactly. By reducing shedding, you decrease the overall viral load circulating within a population. This lowers the chance of exposure for other horses and hopefully reduces the chances of widespread outbreaks developing.
So it's a population effect, reducing transmission.
Precisely. There are also specific EHV-1 vaccines that are absolutely essential for pregnant mares to protect against the abortive form. These are typically given as a series during pregnancy, often at months 5, 7, and 9.
Protecting the foals.
Protecting against abortion, yes.
Yeah.
So, while we have to be clear, no vaccine currently licensed guarantees individual protection from the neurological form. EHM, the strategy is that by reducing overall viral circulation and shedding.
You indirectly lower the risk for everyone.
That's the hope, yes. It may theoretically lower the overall risk of EHM appearing in a population, but it's not a shield for an individual horse against EHM. Vaccinating unexposed horses during an outbreak might help decrease spread further. But vaccination is contraindicated, meaning it should not be done for animals already showing neurological syndrome. You don't vaccinate a horse that already has EHM.
Right, okay. And how often should horses be vaccinated?
Depends on risk. For certain horses, like those traveling and competing frequently, the United States Equestrian Federation requires vaccination every 6 months. For animals considered at particularly high risk, vets might recommend vaccination every 3 or 4 months. It's about maintaining immunity to reduce that shedding.
So it's a layered defense, biosecurity first, then vaccination to reduce the overall viral challenge.
Exactly, a multi-pronged approach.
So after going through an EHV infection, maybe surviving EHM even, what's the outlook for horses? What can owners typically expect for their equine partners?
Well, the prognosis varies significantly depending on which form of the disease they had.
Makes sense.
For respiratory disease, the good news is most horses recover from uncomplicated infections uneventfully. Give them that rest, 2 to 4 weeks, and they're usually fine.
Okay, good prognosis there generally.
Generally, yes. If we consider reproductive tract disease, the mare herself usually recovers readily from an EHV-induced abortion. And importantly, her subsequent fertility is generally not impaired, which is good news for breeders looking to try again.
So the mare recovers well physically?
Yes. Now, for neurologic disease, EHM, it's more variable and depends heavily on the severity. Many horses stabilize within 24 to 48 hours of the signs appearing.
Okay, they stop getting worse quickly.
Often, yes. If they remain standing or if they can stand even with assistance, slow improvement usually occurs over weeks to months.
Weeks to months, so a long recovery.
It can be a very long road, yes. And some horses may have long-term residual deficits, maybe some lingering weakness or incoordination. However,
severe cases.
Horses that become recumbent, unable to stand, and cannot rise, even with help, they have a much poorer prognosis. The challenges of managing a down horse, preventing complications, it's immense. And often, sadly, euthanasia is considered in those cases.
A very tough outcome for the worst cases.
Unfortunately, yes.
We've covered a huge amount today. From the chilling reality of EHV's ubiquity, how common it is, and that concept of latent infection.
The hidden threat.
Exactly. To the critical differences between EHV-1, that big player, causing neurological and reproductive disease, and EHV-4, which is primarily respiratory. And of course, we've highlighted the vital role of getting an accurate diagnosis, the intensity of supportive care needed, and these really comprehensive prevention strategies.
Absolutely, and it bears repeating. While there's no magic bullet cure for EHV, a robust, comprehensive approach combining that strict biosecurity, smart vaccination strategies tailored to risk is absolutely essential for managing EHV in our horse population.
It sounds like constant vigilance is key.
It really is. Constant vigilance and a deep understanding of its complexities. But, understanding the enemy is always the first most crucial step in protecting these magnificent animals.
Indeed. And that brings us to a final thought for you, our listeners. Given that EHV can establish this lifelong latent infection lurking beneath the surface, just waiting to reactivate under stress, how might this widespread hidden nature of the virus shape our approach to managing equine health, even when there isn't an active outbreak? What does it truly mean for the individual horse you care for and for the broader equine community that this potential always lurks just beneath the surface of normal health, demanding constant awareness from every single owner and caretaker? Something to think about.